Okay, Joe.
Okay, welcome everybody to this, I think, third or fourth in our series of webinars on palliative care subjects. Today's is about nausea and vomiting and constipation. So these webinars are commissioned by Cardiff and Vale Health Board and delivered by Cardiff University Continuous Professional Development Department. So they are sort of aimed at Cardiff and Vale staff who are working in nursing, residential homes and in social care. If there are people other than that on the call, you're very welcome. But you might need to just check out how your own local services work if we're talking about anything that's sort of Cardiff and Vale specific. But you know, everybody's welcome. Just introduce myself. I'm a palliative care consultant based in Marie Curie in Cardiff, community service in the Vale of Glamorgan and University Hospital of Wales in Cardiff. Professor Fiona Rawlinson, who is my colleague, is course director for the MSc in palliative medicine and helping to deliver the webinars with me. Also on the call, I have got Catriona Seed, who's a clinical nurse specialist at City Hospice in Cardiff, and I've also got Charlotte Stevenson, who is the is running this from the Cardiff University CPD point of view. And last but not least, we have got our two speakers, who are Elaine McLeish, who's clinical nurse specialist with the Marie Curie Community Specialist Palliative Care Team working in the Vale of Glamorgan. And our second speaker, we have Anna Miklitz. I'm sorry if I've pronounced your name wrongly, Anna. And Anna is a recent graduate from our Masters in Palliative Care programme, did her dissertation on constipation and is going to talk to us a little bit about constipation, and is a member of the nursing home staff at the Manor House Nursing Home in St Hilary. Please fill in the evaluations for us towards the end of the webinar, because that really helps us to guide how to pitch these and to consider when we deliver more how best to address your questions. Any questions as we go? If you would like to put your hand up and speak, that's absolutely fine. If you're more comfortable putting questions in the chat, that's also absolutely fine. Is there anything else that I need to mention before we move on? No. Okay, thank you. So I'm going to introduce Elaine McLeish first, who's going to talk to us about nausea and vomiting. Thanks.
Thank you, Jo, and thank you for the introduction. As Jo said, I work for Cardiff and Vale and community team, and based with Marie Curie, and mainly we're based in the Vale of Glamorgan. And I'm going to talk to you today about nausea and vomiting, which is quite a distressing symptom anyway, and especially in our palliative care patients, it can be one of the most distressing symptoms and unpleasant as well, and cause a lot of other side effects. And the literature suggests that it's the most common symptom and it affects 70% of patients with advanced cancer. And often with nausea and vomiting, it's not just one cause. It could be multifactorial, which can cause problems when trying to manage it. So just a quick look at what is nausea and vomiting. So there's three separate, we've got nausea, we've got vomiting, and we've got retching. So nausea is a sensation of the desire to vomit. And sometimes you might find in some patients that they feel nauseated, but they don't always vomit. Vomiting is the action of expelling gastrointestinal contents via the mouth, and that's more obvious than vomiting, and that's very distressing as well. And then some patients, they just have the retching, where they're trying to vomit, but there's nothing to come up, and that can be extremely distressing as well. And as I said, patients can have more than one cause of nausea and vomiting. And I've listed some of the main things to consider when you're doing your assessment and looking at the causes. So the first more obvious one is gastrointestinal. So basically, if they've got some gastric stasis, intestinal obstruction, or sometimes constipation can often make patients feel nauseated, because basically food is not moving through the gastrointestinal tract, and it's just staying in the stomach, and then obviously that gives you a feeling of fullness, and then you feel you want to be sick or you feel nauseated. A lot of drugs can cause nausea. Opioids is the main obvious one. So your morphines, oxycodone, strong painkillers, antibiotics, non-steroidal anti-inflammatories, iron, digoxin's another one that can often cause nausea. Then you've got your metabolic causes as well. So if somebody's got a high calcium, then they can feel very nauseated and vomit. And poor renal function, because sometimes the medication, if it's not been excreted well in the kidneys, can build up and make people feel nauseated. Then you've got your toxic causes, so things like radiotherapy, chemotherapy, infection. And very often with chemotherapy, patients have antiemetics prescribed as a precaution as well to take with the chemotherapy. Brain metastases. This very often, if you've got raised intracranial pressure, can make people feel nauseated and vomit. And then you've got your psychosomatic factors. So things like anxiety and fear can often make people nauseated and want to vomit. And severe pain as well. A lot of people don't think about pain, but this can cause a feeling of nausea and vomiting. So how do we manage this? And I think the main thing is to carry out a thorough assessment, because obviously there could be a few different causes of the nausea and vomiting, so you want to have an accurate assessment. So look at the history of the nausea and vomiting. When did it start? Look for obvious triggers. So things like, have they started any new medications? Have they had any treatments? How long has it been going on for? Then when somebody is vomiting, think about the contents of their vomiting. Is it undigested food? Is it fecal matter, which would suggest an intestinal obstruction? And sometimes when you've got gastric stasis, people vomit straight after eating food. So think about that when you're taking a history as well. Then look at your investigations, any biochemistry. So have they got a high calcium? Is their renal function poor? And then obviously looking at the drug regime, have they started on any medications that may have made them feel nauseated? Could it be the chemotherapy medication? So just reviewing the drugs. Are they taking too many medications? Can we cut down on medications as well? And then any associated symptoms, so things like headaches or raised intracranial pressure, could be suggestive of brain tumours. So assessment is key really when you're looking at how to manage it. So once you've done your accurate assessment, how are we going to manage it? Now, I've started off with non-pharmacological management to start with, just some simple things that you can look at. So is there any smells that could be contributing to them feeling nauseated? So have they got a stoma? Have they got a fungating tumour? Could we mask those smells? And it's really important to provide a calm, reassuring environment away from the sight of food and smell of food. And especially if people are feeling anxious as well, you want them to be calm and reassured. Is there any foods that are making patients feel nauseated? So they want to avoid exposure to that. The other thing as well is eating small amounts more often rather than large meals can be helpful. So we often say to patients to snack throughout the day. So small amounts of high calorie foods more often rather than having a large meal. If a patient's at home, we often see patients in their own homes, and they often have to cook. So it may be that they could ask somebody else to cook for them, because if the cooking is making them feel sick, then get somebody else in the house to cook for them. Something else that we can think about is things like acupressure, relaxation, hypnosis, complementary therapies can be very effective for patients who have like an anxiety factor to their nausea and vomiting, or they're frightened as well. So these relaxations can be really effective. So once you've looked at your non-pharmacological measures, the other thing you can think about is treating the reversible causes. So I mentioned earlier, if somebody's got severe pain, review their pain medication. Can we get their pain better controlled that might be able to help with the nausea and vomiting? Why are they having severe pain? Has there been a change in their symptoms? Is the pain associated to the vomiting? So we can look at that as well. Have they got an infection? Is there any other signs of infection? Do they have a temperature? Have they started on antibiotics? Have they got a cough? Sometimes a cough, vomit when they're coughing. So do we need to treat the cough as well? Now, hypercalcemia, that is often a very common side effect of hypercalcemia is nausea. Do we need to treat the hypercalcemia? Constipation. Now, Anna's going to talk to you later about constipation. So it's making sure that are their bowels opening well? Do we need to introduce laxatives? Oropharyngeal candida. Now, patients often have oral candida, but sometimes it can be at the back of the throat as well, and that can often make them feel sick. To think about treating that. Tensicitis. Obviously, if we've got tensicitis, then there'll be a bit of gastric stasis, so food doesn't move around so quickly. So we need to get a patient in to have a paracentesis. Raised intracranial pressure. If somebody's got a brain tumour, do we need to think about reducing some inflammation with steroids? And sometimes it can be a balancing act. We could increase the steroids. It could help to reduce the pressure. And then the drug-induced, which I mentioned earlier about morphine. Very often when we start patients on strong painkillers like morphine, we often start an antiemetic straight away as well. Because sometimes they do have the feeling of nausea, but that usually passes within a few days. And you can say that to patients. But I would also introduce an antiemetic at the same time just to prevent that. And then looking at the anxiety, do we need to treat the anxiety with things like relaxation, any medication? And obviously, do they need to be referred for counselling? So looking at all your reversible causes can also help with your management of the patients with nausea and vomiting. So once you've looked at the non-pharmacological measures and you've looked at your reversible causes, the next thing you need to consider is your medications. So with the pharmacological medications, we've got medications, antiemetics, which basically block the iatrogenic reflex in the brain stem. So we've got multiple neurotransmitters in the brain, and so just simply the vomiting centre in the brainstem triggers the vomiting reflex, and the vomiting centre receives input from throat, abdominal organs via the vagal and splanal afferents. It all sounds quite complicated, but that's the pathophysiological. Let me just read it out to you. So the chemoreceptor trigger zone lies in the brainstem and partly outside the blood-brain barrier and receives input from both the circulation, drugs and toxins, and from multiple neuroendocrine pathways. And basically the medications try to look at the receptors in these pathways to trigger then the preventing the vomiting and the nausea. And we've also got drugs that act in the gastrointestinal tract. So these are called prokinetic agents that help the food to move through quicker. Then we've also got drugs to reduce the volume of gastrointestinal secretions, and these are anti-secretory agents. And then you've also got your adjuvant drugs, for example, your corticosteroids. So when looking at drug choice, obviously we want to look at the cause of the nausea and vomiting first, but very often we don't always know the cause. We may not have done all the investigations, but we want to start an antiemetic straight away. So if the cause of the vomiting is unclear, we would want to start, we can use the antiemetic ladder. So you would select a drug. Very commonly we start with something like metoclopramide, and that is in the first step of the ladder. Then you can move on to, if that doesn't work, use an alternative one, something like cyclizine. And then if that doesn't work, you can often use a combination of the drugs together, which can often help. And then step spectrum drug, for example, levomipramine. And there's also, you've got dexamethasone to consider as well, because that can be really effective, especially if you've got raised intracranial pressure, but it can also be effective if you don't know the cause of the vomiting or the nausea. Very often we do know what's causing if we do know what's causing the nausea and vomiting. I don't know how clear that slide is actually, but we have got certain drugs of choice that can help. So for example, if you're dealing with something like toxins or drugs, haloperidol can be effective. Radiotherapy, haloperidol can be effective as well. If it's something like hypercalcemia, metabolic, then haloperidol can help. Raised intracranial pressure, cyclizine can be effective. If you've got bowel obstruction, we would tend to think about something like cyclizine or a combination cyclizine and haloperidol or hyoscine butyl bromide. If you've got delayed gastric emptying, then we would think about something like metoclopramide. And then often thinking about gastric irritation, you would want to check to see if a patient is on a proton pump inhibitors like something like omeprazole or lansoprazole. And you would often stop the gastric irritants like your non-steroidal anti-inflammatory drugs like ibuprofen. So that's a bit more of a targeted approach with your antiemetics. And just looking about the drugs in a bit more depth. So I mentioned earlier about receptors and how the drugs attach onto receptors. And I always find this diagram really helpful when thinking about the combination of medications. So these antiemetics work because they bind to specific receptor sites. And there's like quite a few different receptor sites. And if you look at the drugs, you can see why a combination can be helpful. Like very often we can prescribe haloperidol and cyclizine together because if you can see, they hit quite a lot of receptor sites. Something like levomipramine, it's always been described as the domestos of antiemetics. As you can see in the diagram, that it hits a lot of receptors. So if all else fails, we often think about something like that, levomipramine, because it hits a lot of the receptor sites. So in summary, I mean, nausea and vomiting can be a complex symptom to control, but there's a few general points to think about. Always give antiemetics regularly, not on a PRN basis. And I often speak to patients about it's like pain control. If you're having regular pain medication, then you can keep on top of the pain. It's the same with the antiemetics. Give it regularly, not on a PRN basis. So if the vomiting's preventing the drug absorption, think about an alternative route. So think about something like a syringe driver. Some patients don't always absorb the medication. So if you're using a syringe driver, it can help to get the medication settled and getting something in quickly. So dexamethasone, as I mentioned earlier, that can also be effective for nausea and vomiting if we're not quite clear what's causing it. And as I said, check your bloods, check the renal function, the liver function, check for hypercalcemia. Renal function, often you might need to consider if the renal function's poor, do we need to reduce something like morphine, or do we need to rotate to a different opioid as well? Because that could be contributing to the nausea. The other thing to think about when you're given a prokinetic drug, for example, metoclopramide, if you're using it in somebody with intestinal obstruction, it can cause a bit more colic. So you'd need to be careful of that when using it. And always reassess the patient regularly, as the cause of nausea and vomiting can change. Symptoms change over a period of time depending on what's happening with the patients. They may be having chemotherapy, they may be having radiotherapy. The symptoms might settle down, there might be a different cause of the nausea and vomiting. So it's really, really important to just continually assess your patients over a period of time. Now, I mentioned earlier about the drug levomipramine as the domestos of antiemetics is very, very good, but it tends to cause sedation. So that's why we don't tend to think about going for it first. So you need to consider that when you're prescribing it. So start in a very small dose and build it up. But it can also be very helpful if someone is anxious as well with the nausea and vomiting, because it can help to relax them. We use octreotide to dry up gastrointestinal secretions, and this can often make people constipated. And ondansetron is another antiemetic that is very, very effective when patients are having nausea and vomiting with chemotherapy. But it's often associated with constipation, so you need to make sure that patients are on their regular laxatives as well. The other two drugs that we tend not to prescribe together is cyclizine and metoclopramide, because cyclizine can antagonise the prokinetic effect of metoclopramide, and we don't usually mix them. Usually if they're prescribed together, they tend not to be effective and work, so we usually don't think about using the two of them together. Is there any questions? Thank you.
Thank you, Elaine. There is a couple of questions, but whilst everybody else has a quick think, any questions you've got, pop them in the chat quickly. Thank you very much to Elaine for speaking. And while you're just having a think, I forgot about our polls to start with. So I wonder, just to check who we've got on the call, whether Charlotte was able to put the polls up. Charlotte, would that be all right?
Yep, so you should be able to see the first poll now, which is in what setting do you work? So if you're an attendee on the webinar, just pop your answer there, and we should be able to let Joe know who we've got on the call and what setting you work in. So we've got 50% community and 50%, oh no, it's all changed, 33% community, 33% mainly secondary care, and 33% a mixture. So that's that one. And then if you all do the same for the next poll, which is what is your main role? And we've got the responses are just coming in now. We've got at the moment a mixture between, it's all changing all the time, 33% nurse, 17% district nurse, 17% nursing or residential staff, 17% doctor other than GP, and 17% GP. So a bit of a mix there.
Thanks, Charlotte. Well, as I said, everybody's very welcome, and there's a whole mix of people there. But I'm really pleased to see there's a reasonable number of nursing and residential home staff there as well, because they were one of the main groups that we were aiming at. So thank you, everybody. So to our questions, there's one about opioids. Can you see them, Elaine?
Yeah, I've just had a quick look. I'm not quite sure. I think I might have answered that with the opioids. Usually when patients start the opioids, it usually takes a few days, 2 to 3 days. That's what I say for the nausea to subside. I don't know if you would agree with that, Jo. That's what I usually...
think so. Yeah, if people feel a bit sick when they start a strong opioid like morphine, we often, as Elaine said, give them anti-sickness medicines as well as their painkiller, but would sometimes say after 2 or 3 days, it might be worth cutting down on the anti-sickness tablets if you don't feel sick at all, just to see whether you still need them, because often after the first few days, it will settle down, but not always. And people might find that they feel sick again when they cut down their anti-sickness medicines and need to restart them. So I think that was the answer to that. And then there's another one here from Frederick. Should it be routine practice to monitor the RBS level for patients who experience nausea and vomiting? So I'm sorry, I don't know what RBS level is. Can anyone else tell me? Or Frederick, do you want to put that in the chat? So I'm sorry, we don't know.
I wonder if it's random blood sugar. Frederick, am I right? Is it random blood sugar, maybe?
Okay. So I don't know, Frederick, if you're thinking that if you are a diabetic patient who's on treatment for diabetes, so some of the tablets like gliclazide or some of the different types of insulin can make your blood sugar go low at times, especially if you're vomiting. And if you've got a very low blood sugar, you might be quite nauseated. So it would be a reasonable thing to do to check a BM in people who are sick, especially if they're diabetic, especially if they're on either tablets or insulin. Does anyone else want to add anything to that? Oh, random blood sugar level, thank you. Okay. Anybody else got any questions? As I said, while you have a think, there was just one thing that I was going to mention, which we don't have to go into all of the detail about receptors particularly, but it's probably worth just remembering that for patients with Parkinson's disease, which will be quite a few people in nursing homes and people who are frail and elderly, we need to perhaps remember not to give patients with Parkinson's things like metoclopramide or haloperidol, because the way they work can worsen the Parkinson's disease basically and make people's muscles more rigid. So that's worth just bearing in mind. So for people with Parkinson's, they can have domperidone, but that only comes as a tablet, and they can have cyclizine, and they can have ondansetron. Any more questions? Or I'm sorry, I feel like I've done lots of talking. Anybody else of my fellow panelists have anything to add?
No, I think that one of the most useful things with nausea and vomiting is what Elaine said first, really, which is just, we tend to think it's nausea and vomiting and it all goes together, but actually it's really worth spending, 20 seconds. It doesn't take very long, but just seeing if you can disentangle, is it nausea or is it vomiting? just because if somebody is vomiting without very much nausea, that gives you quite a more of a clue that it may not be like a chemical thing. And it's just sort of little frameworks like that, I think, can be really helpful. But I think, I mean, we all, in a sense, we can all trigger that feeling of nausea, can't we? Just kind of thinking about the last time when we were feeling sick or had gastroenteritis. I think it can be such a debilitating symptom, and for people who may find it difficult to communicate, they tend to withdraw, don't they? So the person who actually just is very quietly sitting, it may be that they're sitting there because they're just feeling a bit sick, and there are so many things we can do just to try to make them feel a bit better. But I think that's sort of just the main, if you like, reflection over many years. So thank you. Thanks, Elaine.
Thanks, everybody. Thank you, Elaine, for speaking. You can continue to put questions in the chat if anything comes to you as we go on, but we're probably about halfway through now, so we've got about 30 minutes left, and I'm going to hand over to Anna McClick, who's going to talk to us about constipation, who, as I said, is one of the nurse managers at the Manor House Care Home, which is in St Hilary, out in the beautiful countryside in the Vale of Glamorgan near us. So Anna, I'll just let Anna share her slides.
Can you see my slides now?
We can, Anna, but do you want to just put them on slideshow for us? Great, thank you.
Yeah, there you go, there it is. Let me start. So hello, everyone. Thank you for having me today. And yes, my name is Anna, and I'm clinical lead nurse in the Manor House in St Hilary. And I would like to talk to you about the constipation today. Maybe put this down. Yeah. So the aim of the session is to improve knowledge about the constipation in the palliative care patients. Objective is to define constipation, identify and assess causes of constipation in palliative care patients, describe use of pharmacological and non-pharmacological ways to manage constipation. Anatomy, physiology, just a refresher. It is important to remember about or refresh the knowledge because it will explain why we have difficulties with constipation. Main functions of the large intestine is to storage, absorption, secretion, synthesis, and elimination. Interesting fact is that 70% of unabsorbed food residue is extracted within 3 days, and 30% may stay for up to a week. Other interesting facts is the woman colon is longer than the man. The anal canal is about 3 to 4 centimeters long in women and slightly longer in men. And possibly this is the reason why men need a little bit more time to relax, to open the bowels properly. The content spends 2 to 4 hours in the small bowel and 48 hours in the colon. Normal transit time for healthy people is from mouth to colon to rectum is 32 hours in men and 41 hours in women. Possibly this is why women get more constipated. For patients receiving palliative care, that transit time is between 4 to 12 days. Important muscles in anal canal are internal and external sphincters, and they are responsible for our continence. Internal one is involuntary and we don't have control of it. It automatically keeps the anus closed. But if it gets weak, patient has passive soiling. External sphincter is the muscle we can control, and that's why sometimes we are able to hold the wind or diarrhea. However, when that muscle gets weak, patient has a fecal incontinence. This muscle can be exercised though and made stronger. Bowel function to describe, we need 3 indicators. It's the frequency, consistency and amount, and difficulty to open bowels. We can't say what is normal because normal varies from individual to individual, the same as frequency varies from patient to patient. You might have patients who open regularly bowels every day, and patients who will go every 3 days, 4 days, 5 days, or palliative care patients who will go every 10 days sometimes. But the rule is rule of 3. And I think it's important to remember that, because if you use that rule, it's much easier to guide yourself in a clinical setting. So rule is no longer than 3 days and no more than 3 times per day. Healthcare professionals using the ROM4 criteria for diagnosis of clinical constipation is the escalation of 2 or more problems over the past 3 months. And it could be straining, passing lumpy hard stools, sensation of incomplete defecation, sensation of anorectal obstruction or blockage, manual maneuvers to stimulate or evacuate the bowels, or if the patient has less than 3 spontaneous bowel actions per week. It's important to remember that diagnostic tool not always gives the accuracy in measuring occurrence of the symptoms, because the patients with dementia, they have difficulties to verbalize those symptoms or the concerns. Constipation is a major clinical and nursing problem and affects 40% of general population, 20 to 50% older and clinically ill patients, and 80% of palliative care patients. So let's think about patient story. Let's imagine Jim. He's in a nursing home. He's 80-year-old gentleman with advanced dementia. He can communicate, he can verbalize his needs, he's pleasant, but confused sometimes and forgetful. He suffers from type 1 diabetes, so he's insulin dependent. He's got hypertension, depression, and osteoporosis. Usually he's very pleasant, very alert on interaction. He loves his food. The appetite is always good. He's able to eat independently and drink independently. He walks with a walking stick, and he's accessing toilet independently as well. He doesn't like staff to attend him or assist him or supervise him when he goes to the toilet. He's a very private person. And one day he was found more confused, more lethargic. His mobility reduced, his appetite went poor, he wasn't hungry, he didn't want to eat. He couldn't specify his symptoms as such. His blood sugar was unstable. He was denying that he's got any pain. He was denying constipation or nausea. So we called for the doctor. The doctor came to check the chest. Chest was clear from infection. Abdomen was very difficult to assess because Jim was always overweight and his abdomen was large and very hard to touch. However, there were bowel sounds present in all 4 quadrants. When checked per rectum, there was no impaction. Staff managed to take some urine. Abdomen was very difficult to assess because Jim was always overweight and his abdomen was large and very hard to touch. However, there were bowel sounds present in all 4 quadrants. When checked per rectum, there was no impaction. Staff managed to take some urine sample and the urine dipstick was negative. So advice was to continue to monitor. Unfortunately, Jim's condition deteriorated over the night. His blood sugar reached dangerously high levels, and he was admitted to hospital. And in hospital, he was diagnosed with fecal impaction. So prevalence of constipation in nursing homes, it's 50% of nursing home population suffer from constipation or chronic constipation, and 7% of newly admitted residents experience constipation during the first 3 months. I think it is related because it's the new environment and maybe changes of the needs or needs to be assisted to the toilet. 80 to 90% of dementia patients experiences fecal incontinence. Uncontrolled constipation is related to poor recognition of the symptoms. And we can see it on the Jim's experience, or Jim's story. So what are the risk factors of constipation? We've got primary causes and secondary causes. Primary causes is reduced fluids and fiber intake, poor diet intake, decreased activity, mobility, increased age. As I mentioned before, females get more constipated. lack of privacy. It is very important to create this sense of privacy and routine for the patient. Using bedpan or commode can be physically uncomfortable, and sometimes accessing toilet is difficult for patients who are paraplegic or very weak or fatigued or just waiting for the assistance. Embarrassment because if they're changing the environment, the patient is newly admitted and there is new setting around, and suddenly from being independent at home, now they required assistance and they feel very embarrassed that staff is waiting for them to finish to open the bowels, for example. Pain on defecation. If patients got hemorrhoids or fissures or cancers, they might experience pain, and that stopped them from opening bowels so often. They will hold it for long periods, so the feces will be moved higher up, and then they've got difficulties to open it properly. Secondary causes, so it will be structural, as I mentioned, tumors, cancers of the pelvic, of the abdomen, or muscle weakness, hemorrhoids or fissures. Metabolic, it's electrolyte abnormalities, renal failures. Psychologic, depression, because patients might not be motivated enough to go to the toilet, or painful past experiences. Iatrogenic, it will be the medication like opioids, for example, and I will tell you about it later. Neurologic conditions like paraplegia, stroke, or Parkinson can affect the bowel function. So what's the causes of constipation for patients receiving palliative care? We'll have three. It's malignancy, medication, and disease they've got. In malignancy, because of the tumor, can have an effect on the bowels, on the intestinal obstruction, or cause damage to lumbosacral spinal cord, or have hypercalcemia. And secondary effects, because patients with cancer, they very often are not feeling hungry. The intake is very poor. They're not taking adequate fiber, or they are very dehydrated, they're very weak, they're inactive, they're resting on bed, or they are bed-bounded. They might feel very depressed, so the motivation is very low to access the toilet, or changes in environment. They also got not only tumors, but they might have other conditions like diabetes or hernia or rectal prolapse or stenosis, hemorrhoids, or neurologic conditions which affect the bowel function. And to manage patients in a palliative care setting, they need to have symptom control. So to control the symptoms, they need medication. And side effect of the medication, like opioids, they're slowing the bowel movements and causing constipation. So in opioids, we will have some morphine-related medication, buprenorphine patches, oromorph, MSTs, and other drugs like hyoscines or antiparkinson agents, diuretics, iron therapy, gabapentin, or neuroleptics like haloperidol. And that's why 80% of palliative care patients suffers from constipation. Age, constipation increases after the age of 65 years, and elderly patients are troubles with the constipation because diminished rectal distension. The diet is less in fiber. They might have difficulties to swallow or chew the food. They've got lost ability to distinguish what is wind and what is the solid feces because the impaired rectal sensation. And also because decreased in anal squeeze pressure, they're very weak, they don't have the strength to push things out. The muscles are very poor and they've got tears or fragile tissues. Dementia. Dementia and dysfunction for successful toileting is related to reduced mobility to reach the toilet. They've got reduced motivation to use the toilet, or they not recognize the toilet as a place to open bowels. They've got maybe difficulties to locate the toilet. They're very unfamiliar with the environment. When they're coming from home to the nursing home, everything is new. They might have difficulties to adjust the clothing in time, or they might go on the toilet, forget they haven't finished as yet, and they're pulling things up, pulling up trousers, thinking that they finish. Difficulties to verbalize the toilet needs. They might have reduced ability to initiate defecation. They've got reduced ability to maintain appropriate body position, and they might feel very embarrassed after soiling. So you might find patients with dementia wrapping their bowels in the feces in a tissue. They don't understand sometimes how the body functions, so you might find patients trying to self-evacuate as well, and they suffer from depression. So what clinical manifestation, the symptoms? I think thinking about constipation and symptoms, we need to take a patient as a whole patient, like multi-dimension problem, because it affects physical, psychological, and social aspects of patient well-being. In physical, patient might report to you, but patients with dementia might not, so you have to be very, very aware of that they've got abdominal pain, cramps, gut colics or lower back pains, abdominal distension, delayed defecation or hard stool. Wind might be a little bit offensive. They feel that they're straining when they're opening the bowels, or they have nausea, vomiting, heartburns. They feel full, they not feel like eating, they might lose weight because the appetite is very poor. They might complain of headache or feeling just generally unwell, but can't specify the symptoms as such. They might decrease the mobility because they're very sleepy and lethargic, but they might be very restless because of the impaction. Sitting is very uncomfortable. In psychological aspects, patients with constipation might become very irritable, very angry or agitated, very unhappy, sleepy or lethargic. They might have increased confusion or hallucinations. And that in overall will cause the social isolation. They not feel like interacting with others, and family might feel very anxious as well, because they see that there is a change in the mother or father presentation, and they not want to talk to them, or they just see how they are unwell, and that makes them anxious. What's the complications? Impaction, as you can see on the photo on a slide, it shows how much it affects other organs in the body. So impacted fecal mass will press on urethra and bladder, and that might cause urinary retention or blocked urinary catheter, resulting in UTIs. It can cause urinary incontinence, but also stretching the pelvic floor might cause back pains. If the patients strain too much, they can lead to arrhythmia, raised blood pressure, heart failure, or hemorrhoids. And in the very bad cases, it can lead to intestinal obstructions or bowel perforation, admissions to hospital, and even death. Other mental problems like confusion, delirium, and hallucinations are the complication of the constipation. So to sum up about the constipation, it's one of the most distressing symptoms. Infrequent bowel evacuation with a hard, small feces or difficult, painful defecation. However, there is no universal agreed definition about it, and this lack of inconsistency and lack of precision about the definition of constipation challenges the ability to properly assess patients, especially patients with dementia, because they've got difficulties to verbalize the symptoms. And just remember that constipation is a multidimensional problem. It affects physical, psychological, social aspects of patient's life, and also affects the family. It's very subjective symptom. Patient might describe constipation subjectively using different measures, and dementia patients might present very non-specific symptoms like anorexia, agitation, and that's why constipation very often goes unrecognized and untreated. So accurate record keeping and monitoring is very important. It might prevent, it helps to assess and treat constipation. We're using Bristol stool chart to record consistency, and type 1 and 2 will describe as a constipation. It's important to involve all staff members in record keeping. I think the palliative care delivery is a team effort, so everyone knows the residents well, and if we communicate with each other, we can keep accurate record keeping. And every evidence is very important. Like, remember about Jim, he was flashing his evidence and it was not recognized that he was constipated. Also, I think if we involve residents in record keeping, it's also important, because it's not only supports early recognition, but it helps the patients or residents to foster the sense of the autonomy, help them to have a control. So how we can prevent constipation? First of all, we need to identify the patients, ask the question, is the patient is at risk of constipation? And if the answer is yes, because it's a newly admitted resident, because of the medical history, new medication, we introduce the buprenorphine patches or opioids or iron therapy, or residents became more bed-bounded, then we can discuss with patient the non-drug treatments or establish the laxative regime which prevents patients from becoming constipated. Managing constipation. It's important to have a thorough assessment, investigate what causes the constipation, and then treat. In assessment, we've got history. That's why this record keeping is so important, because it will tell us what is patients' bowel habits, what is normal for the patients, and if we see any difference of or when was the last bowel movement recorded, it's easier for us to find out the reasons. The frequency and appearance of feces are also important. Symptoms. So let's check with patient about the pain, bloating, feeling nauseous, or mood behavior changes, or have they changes the eating, drinking, or moving, if they're less sleepy or lethargic. That's why in a nursing home is so important. If we know our patients well, we can easily recognize that something is not right. Let's find out why. Medical history, so have they got malignancy, concurrent disease, any other problems? Medication, as I mentioned before, maybe we introduce the new medication like opioids, then start to examine patients, check the abdomen, is that the standard, is there any tenderness or fecal masses present? Talking about non-drug treatment, increase fluid intake, increase fiber diet, offer and assist patient to the toilet more often, ensure privacy, and that creating sense of privacy is very important because it helps residents to relax and make sure that bowel movement is effective. Correct position also helps in the bowel movements, and in that picture over there you can see that rising knees above the hips and proper position helps to bulge out abdomen, and straighten your spine helps to open bowels properly. Encouraging mobility within capability, it's also important. A little bit of activity helps bowels to maintain the movements, and review medication. Before we start any medical treatment, it's very important to consider few things. Speak to the patients, what's the preferences and abilities. We need to know, is the patient's likes and dislikes? Is the patient able to take the big volume of medication, for example, Laxido, which needs a glass of water at least, and more fluids to be taken throughout the day, because palliative care patients, they're not able to take so much fluids. Form of the medication, they prefer the tablets or they prefer liquids, or maybe they're not able to swallow the tablets because they've got swallowing difficulties and they need to have liquid. And also, will patient manage regular administration, because having the good effective medical treatment, we need to make sure the patient is able to follow the regular administration of the medication, that they take the medication as they are prescribed. Separating softener and stimulant also helps to separate softener and stimulant allows optimum stool frequency and consistency, keeping medication to minimum, and consider the route of administration. Stimulants, if they are administered orally, they will act in 6 to 12 hours. Rectal medication will act between 15 and 60 minutes, but it also depends on the preferences of the patient or abilities. If the palliative patient is not able to take oral medication, then the rectal administration will be prescribed. We also have to be aware of the side effects. Senna might cause colic, and lactulose side effect is bloating. So sometimes it's good to give the lactulose between the meals if the patient will complain about bloating. If there is any suspicion of the bowel obstruction, we need to seek specialist advice and hospital admission. So medical treatment. Type of laxatives, we've got oral laxatives like bulk foaming laxatives, softness, osmotic laxative as stimulant laxatives. Bulk foaming agents, they're not very popular, let's put it that way. They stimulate bowel, but they use as a preventive form than treating the constipation, because they causing, or they might cause, fecal impaction, and they require from the patient to take a lot of fluids to prevent that fecal impaction. Stool softeners, they are low effective in constipation, but they are more like a prevention of constipation as well. And one of those medications would be Docusate. They are sometimes prescribed for patients because they're helping to reduce the straining during the defecation. Osmotic laxatives, they act as drawing the water from the body to bowel to soften the stool. And I'm sure you know medication like lactulose, Movicol, or Laxido. They do require, though, to maintain adequate hydration to compensate for fecal fluid loss. And stimulant laxatives, they are like irritant laxatives. They stimulate the muscles in the bowel. And types of that medication, it will be Bisacodyl or Senna. They're very helpful for patients who are taking morphine, because they help those who got difficulties to push it out, because they're helping to increase the evacuation and helps patients to open bowels properly. Other treatment, it will be softness like suppository, and stimulant suppository, and microenemas. I attached some references here, and if you've got any question, please don't hesitate, and we will be very happy to answer.
Thank you so much, Anna. That was very comprehensive talk through of constipation and all of the possible treatments. And yeah, good pictures too.
Thank you.
Well, everybody has a bit of a think about whether they've got any questions. Do any of my fellow panelists want to add anything?
Can I just ask you, Anna? So in your experience in the care home where you work and you manage, is there kind of just bearing in mind there's a reflection in the chat from it's so difficult with all the interventions because the general condition of the patient is so frail and they might not be getting any better. Is there kind of a simple thing that you've discovered over the last sort of couple of years that seems to really make a difference? Just so sort of, sharing your experience with everybody else on the call.
I think the best in a nursing home setting is, as I said in my presentation, is the teamwork. It's working together, team effort. the responsibility lies not only on the nursing team, it lies, I think, on everyone, all members of staff, is it clinical or non-clinical departments, because we all know our residents really well, and we can observe what is normal, how they behave when they are well, when they're smiling and talking to us, and then suddenly the behavior changes, they're irritable, they're angry, they're not happy, or they start to hallucinate. Then we can recognize that something is wrong. And I think the accurate record keeping is really essential, is really very helpful to prevent, because prevention is better than cure. We always say that. And prevention of constipation is so important, because constipation can cause such a bad symptoms and affect all the aspects of patient's life, and the quality of life, the well-being, and then also family. It's like a chain. So it's good to make sure if the accurate record keeping can tell us about patients' habits, and it's important to know then when they and how they opening the bowels. It helps to treat and choose the adequate medication to it, and helps to treat, because if we know if the medications are effective, we can increase or reduce, change to something different. So yeah, I think the teamwork and observation and relying on the families as well. Families are so important. They know their parents very well. They know how they behave, or what they used to take even at home, what was working for them well. So everyone is so different, and I think it takes sometimes a lot of time to know the patients well. So if we have information from family, it's very, very, very helpful.
Thanks, Anna. And there's just a question in the chat about fruits and vegetables. So can fruits and vegetables be effective in managing constipation? Certainly they can, but shall I let you elaborate on that, Anna?
Yes, definitely. Fresh fruit salads are very, very good. Oranges, apricots, prunes, beetroots are great as well. Pears, I know people who, if they have a pear in the morning, the bowel movements is regular. And I also go to the patient as individuals, because everyone is different and got different preferences. Some prefer prune juice. The other prefer the apple juice and have an apple or pear. So I think taking the preferences of the patients in the diet is very important. But yes, definitely fruit and veggies, definitely.
And I would say it's well worth thinking about all of the non-drug things you can do to try to prevent constipation before automatically reaching for medicines, because how much nicer is it to eat some fresh fruit if you can, than take things like Laxido, which I've had the pleasure of recently, and yeah, it's not great. I think I probably will have started prescribing less and less and less of it, but there's lots of different laxatives, and it's about finding something that suits your particular patients, and whether they need liquids, whether they can swallow capsules, whether they don't mind taking 125 mils or however many sachets they have of Laxido. Thank you. Does anybody else want to add anything or any other questions?
I just wanted to add in, it's really interesting, and you were talking about the patients. Sorry, can we?
It's a little bit of vibration going on there. When we're talking about that patient assessment, Hannah, and the challenge is often with those patients who are mobile to the bathroom themselves. So you need that good self-reporting from patients. And I think it's the challenge we have sometimes looking after people in their own home, but also in the nursing homes, is actually that patient who's taken themselves to the bathroom, but maybe they're not evacuating their bowels very well. And they're actually then developing constipation, but it's not being recognised. And what would you recommend to nursing staff when you've got these kind of situations?
It was very echoing, but I think from I gathered was yes, it's very difficult to, it's very easy to unrecognize the constipation for patients who are quite independent and competent. From my experience, it's important to involve the patient into care. Give them the chart, give them the stool diary to make the notes when they have been, because for them every day seems the same. They sitting in front of the television, and they are different only because they've got activities different on Monday, different on Wednesday, and that's how they live on. So if every day is the same and they are forgetful, it's good to give them a chart when they can record things by themselves and they feel very important. They feel that they're doing something important. They feel they've got the control, and it really empowers them to be helpful. They will come to you and they oh, my chart is finishing, can you give me a new one please for the next week? Yes, sure, of course. And if they become unwell, it's easy to have a look on the chart and just check, all right, the bowels were going quite on the constipated side, probably that's the reason you're not feeling well. Let's introduce more fiber, more fluids into your diet. So yeah, I think involving residents in a record keeping is really important. Yes, it really helps to recognize things quickly. Yeah.
Thank you, Anna. We haven't got any other questions. I was just going to add something very quickly. Having said it's really important to think about the non-drug causes, treatment, sorry, for constipation. Most of our patients who take morphine, which is or other strong painkillers like codeine, oxycodone, and that's a lot of our patients in palliative care, isn't it? Most of those people are going to need a regular laxative in order to keep their bowels moving. So unless they've got something that's also giving them diarrhea, like, I don't know, an ileostomy, or that their pancreas doesn't work properly, unless they've got something that gives them diarrhea, then most people who are on strong painkillers are going to need a regular opioid, and it would be good practice to start that when the regular opioid is started. And for any prescribers on the call, because there were some senior nurses and GPs, I think it's worth considering. Certainly in Cardiff and Vale, we've recently got naloxegol or Moventig on the formulary, which is a really clever sort of second or third line medicine for constipation. So it's not something that we should be using before trying the other more simple laxatives. But if somebody has very severe constipation, which we think is due to their opioids, then it's worth considering naloxegol or Moventig, which is really clever medicine because it blocks the effects of morphine and similar medicines on your gut, but doesn't block the effects of morphine in your brain, because if it did that, it would stop the pain control. And there's more information about that on the Cardiff and Vale websites or from any of us who are working in specialist palliative care if needed, and it's specialist recommended, so it's something that should be discussed with palliative care if you're considering it. So thank you. Fiona's just put a message in the chat that we're thinking about effective communication next week. I really hope you can all join us. And if you've got any immediate or particular questions or issues that you'd like to discuss, then pop that in the chat, or you could probably email through to Charlotte if needed. Is that okay, Charlotte?
Absolutely, we've all got my email address.
Great, thank you. And you have put the evaluation slide somewhere in the chat as well, haven't you? I'd be really grateful if you could fill in your evaluation for this session. And Fiona's also put some information on the naloxegol from the BNF. Okay. Thank you very much. I'll stop talking. Thank you to all our speakers. Thanks, Elaine. Thanks, Anna. It was great. See you all next week, I hope.
See you all next week. Hope you can join us.